Welcome. This is Resilience Radio. I'm Irvin Eisenberg, host of the show and owner of Resilience Occupational Therapy. As always, the opinions on this show are not necessarily shared by me. I really like to showcase a variety of different perspectives because everyone has different healthcare needs and different things resonate with them. Additionally, none of this is meant to be diagnostic or prescriptive in any way. Today, we have Chayah Lichtig, occupational therapist and certified feeding therapist. It's great to have you on, Chayah.
Thanks, Irvin.
So I wanted to start off with, obviously, I have my own definition of occupational therapy, but I always like to hear other people's definitions because it's often misunderstood.
Yeah, that is for certain. And having been a pediatric occupational therapist for most of my career, it's doubly confusing as people usually assume that children do not have occupations, right? But you may or may not have defined this on other episodes of your show. But the definition of occupation in the context of occupational therapy is any meaningful activity of your life. And so an occupational therapist's job is, in a nutshell, to enable you to participate in and, if possible, to excel in all of the meaningful activities that shape your life, anything from your activities of daily living, such as eating, sleeping, dressing, and toileting, all the way up to and including any job that you may have, going to school, your recreational activities, and more.
Okay. And there are a lot of different types of occupational therapists, as you alluded to. Can you speak to the work you do specifically?
Sure. Well, I can say pretty generally that I'm a pediatric occupational therapist, which means that my population with whom I work and in whose care, needs, and development I specialize in terms of my knowledge and professional development is the pediatric population, meaning children and youth. And I could say more specifically that what I do now is quite different than what I used to do in the past. I worked for a number of years as a direct service provider, meaning that I was working directly with children, both at times in the home setting and at other times in my career in the school setting. And at this point in my career, what I do is I'm working as a consultant. So my role is really to develop a body of specialized knowledge and to find ways to communicate that knowledge to other professionals to enhance their capacity and their ability to support children and youth.
Okay.
Yeah.
Could you speak to who you consult for and what that looks like?
Sure, absolutely. So in my work, I work for UVM, the University of Vermont, and I work for a center called the Center on Disability and Community Inclusion. And we are one out of many across the country of what's known as UCEDs, or University Centers on Excellence in Developmental Disability. And so UCEDs are these organizations that are really at the crossroads of academia, research, and practice when it comes to the needs of all individuals with disabilities. So what I do at the Center on Disability and Community Inclusion is, at this point in my career, I am a consultant on two different projects. I work as a consultant for the I-Team Early Intervention Project. And then the other project that I work on, which takes up at this point substantially more of my time, actually, is the Vermont Continence Project. And I am one of the consultants for and also the coordinator of the Vermont Continence Project. And so our mission and mandate is that we support person-centered, evidence-based toileting and continence supports for all Vermont residents who are under 22. And we say 22 because legally, according to our grant, that is the age at which a person transitions from childhood to adulthood. It's also the point at which special education services end. And so that's another big transition point for the families of people with disabilities and for the people with disabilities themselves. So yeah, the Vermont Continence Project it's really interesting. It's actually how I came into working at UVM. I started before I became a staff, before I got my staff position at UVM, I was a contractor and a consultant for the Vermont Continence Project for a few years. I was approached by the prior coordinator of the project, who is also an OT, a wonderful, wonderful colleague of mine who's since retired, who I'd worked with on a couple of teams of people who were referred for support with their with establishing toileting and continence support for their children. And she said, I like what you do as a direct service provider. Would you be interested in doing some consultation for us? And my initial feeling was, I don't know the first thing about this, and I could not possibly do it. And after a year or so of doing it, I realized that I was seeing a lot of really, really consistent patterns, and that the concerns and needs of the families and teams were often pretty darn consistent. I like a good pattern. It appeals to my brain. And so here I am now. So 3 years later, I'm the coordinator of the Continence Project, and we do 3 major things. What most people know us the best for is that we do consultation, similar to what I just described with the I-Team Early Intervention Project, though it's different because our audience is sort of a combined audience often of the referred child or youth school team, their medical team, potentially any kind of social services, outpatient services. It can be pretty varied. So we will provide consultation to that team to help them sort of distill and provide language for the nature of why that referred person has a continence concern, and then to develop an action plan for how to address that person's continence concern. And so then the other 2 things that we do are we provide trainings, and those trainings we've done them for a variety of different audiences. Sometimes the intended audience is parents and caregivers. Sometimes the intended audience is educators or school personnel or school nurses. Sometimes it's occupational therapists. For the last several years, the project was actually only occupational therapists, 2 of us. And we do have other disciplines on board now, which is really exciting. And then the third thing that we do, which is taking more of my time and energy this year, is that we create resources and content with the hope and intent that over a long period of time, we can support more people with less need for direct contact. Essentially, like I said, we see so many patterns that are so consistent in the consultation that we do, that we're trying to make as many of the recommendations that we are finding ourselves really frequently and consistently making, to try to make those accessible to a wider audience, so they don't have to wait on our wait list until we're able to do an intake with them, often to tell them a lot of the same things that we've told other teams in the past.
So sort of taking a step back a little bit, what could you describe or define continence and incontinence, and what common causes and common interventions to assist with that?
Absolutely. I would define continence as volitionally, meaning by choice, and intentionally getting all of your voiding and stooling into the toilet. That is full continence. Along with that comes a lot of toileting related skills, right? All of the hygiene and clothing management, not to mention the willingness and the ability to participate in all of those activities. As anyone who has ever had a bladder leak knows, there is no such thing as full 100% continence for for pretty much any given person at any point in their life. And I would define incontinence as the repeated, regular, and ongoing loss of or never having achieved volitional and intentional control of bowel and bladder function. And so for some people, a lack of continence is a lack of the ability to sense and respond appropriately, or I'll say respond adaptively to your body's signals and get yourself to the toilet on time and do everything you need to do into the toilet. And for some individuals, for a pretty wide variety of reasons, a lack of continence is due to some kind of inhibition, fear, concern, or unwillingness to use the toilet. And I see both of those things pretty often in the teams that I consult to. In terms of your question about what are the most common causes, there is one cause of incontinence that is by a massive, massive, massive margin the cause of all incontinence above and beyond any other, particularly in children, and that is constipation. And anyone who has ever attended one of my workshops will know that something that I say all the time is that if what I wanted was to keep myself in business and keep myself in a job, I wouldn't tell you that constipation is the cause of most incontinence. And the reason I wouldn't tell you that is that I am not a prescriber. I am not a nurse and I am not a physician. I do not have a direct hand in helping you to resolve your child's constipation. The reason that I tell you that is because it is, in fact, the number one cause of incontinence, whether bowel or bladder incontinence. And I can explain why if you'd like me to.
Yeah, go ahead.
Okay. So essentially, folks usually think of constipation as being measured only by the frequency of bowel movements, the size of bowel movements, and by what comes out of the body. But my tagline is that you cannot actually measure constipation by what comes out. You can actually only measure it by what stays in. And unfortunately, because we don't have X-ray vision, we actually don't know what stays in most of the time. And even KUB, which is the X-ray screen that's used for constipation, if you see someone at 8 o'clock in the morning, they might look totally constipated. And if you see them at 2 o'clock in the afternoon and they just happen to have the one big poop they have of the week, they won't look constipated at all. And so really the only real diagnostic for constipation is the use of ultrasound, which the vast majority of providers don't have, and which the vast majority of prescribers are not ordering, or providers are not ordering, unfortunately. And I'll tell you why ultrasound is the only way to actually diagnose constipation. It's because the way that you know whether someone is constipated is that you look at how large and how wide the diameter of their colon is. And the reason is that essentially under typical circumstances, the way that our bodies digest food is it comes through our stomach, it starts to get broken up inside of our stomach, and then it goes through a series of little valves, and it ends up in our small intestine, which of course is the really, really long, wiggly one that's sort of in the middle, if you're ever looking at an anatomical scan. And that's where all of the vast majority of the nutrient uptake happens. And then what happens is whatever's left is the waste. And then the waste, of course, goes from the small intestine, the long, skinny, wiggly one, into what's called our large intestine, which is called large because it's wide, right? And our large intestine is also called our colon. And essentially what happens is that when that waste comes into our colon and it comes in right near our right pelvic bone, it's basically liquid. And as that waste comes up that right side, it kind of looks like the shape of a staple. It comes up the right side, straight across, sort of behind and beneath your belly button. And then it goes down the left side and towards your rectum. As it's making that journey over the course of a couple of days, more and more water is pulled out of it until it becomes, hopefully, this appropriate, like soft, easy to pass stool. And so what happens is that when that stool gets to that last section of our colon, also known as the rectum, it fills it up and it stretches it. And when it stretches it, it sends a message to our brain that says, you've got something in there, you need to go, let it go. And then under best circumstances, we go and we have a bowel movement. And then the walls of our rectum, they relax back in and they wait for that sensation to come again. That again tells us, oh, we're stretched out. That means we're full. It's time for us to go and poop. So the problem is that any child who has ever had any kind of traumatic experience, pelvic experience, whether it's around a significant diaper rash, any kinds of pelvic health interventions, or even an oversized, over hard poop, right? They don't get enough fiber, they don't get enough fluid on a certain day. And then the next stool that they pass, it's oversized, it's painful, whatever the case may be. In the future, they don't know any different. I'm just gonna hold this poop in. I'm not letting this poop out because poop hurts. And as soon as we start to withhold our poop, two things happen. Number one, all of that fluid continues to get pulled out. So it gets dry, desiccated, hard, and also it gets really oversized, right? And so then the next time you go to have a poop, it's even worse, right? And then over time, what also happens is that when we don't stool regularly and our colon stretches out, it stops relaying a message to the brain that says, I need to poop. So unfortunately, what happens over time is rather than feeling like we need to withhold, we lose the urge to poop altogether. So what happens is that you were asking about intervention. So here's a little bit of information about intervention, is that once a child has become constipated, evidence shows that non-medical intervention, so just the provision of fluid, fibrous food, etc., is not adequate anymore. You need medication-based intervention at that point. It is just, I resisted it for so long when I first came into practice, and more I saw that people were just not making progress. Because what actually has to happen is that the colon has to become completely emptied out, and then it needs to routinely empty out every single day for months so that it can shrink back to its appropriate size and shape, so that it goes from being a storage organ, which it has been while you were constipated, to being a sensory organ again, so that you can regain the urge to poop. Mm-hmm. Unfortunately, your body is so urgent in its need to get rid of waste that it will get rid of whatever waste it can. You've lost the urge to poop, but you are still having poop accidents. They might be tiny little pellets, they might be smears, right? And then people say, oh, my kid just doesn't care. There's poop coming out of him and he doesn't care. And unfortunately, like, that's something we see really, really often, is that people ascribe volitional, they ascribe malicious or not caring to kids. And you know what I will tell you is that I've worked with so many kids at so many different ages. And if every one of them could flip a switch and stop their constipation, they would in a heartbeat. Nobody wants to be constipated and feeling crummy. Nobody wants to be incontinent and pooping in their 5th grade classroom. It's heartbreaking. Not to mention that 90% of the serotonin in our body is actually produced in our gut, right? And if we are full of shit, then we feel like shit. It's just how it is. And so the other thing that happens, because I did mention that 90% plus of incontinence is caused by constipation, you may ask why that would have an impact, no pun intended, on urinary incontinence. And it's multifactorial. One aspect is, if you just think about the anatomy of the pelvis, you think about these big old intestines that are sitting on top of the bladder. Well, when they are absolutely full all the time, two things happen. Number one, your bladder volume, the capacity of your bladder is significantly less. Number two is that it is just irritating the walls of that bladder all the time. It is just like this big hard thing that is just bouncing up against your bladder. And it's just supposed to be, this loose, delicious, organ fascia connection, all moving and sliding around each other. And it's not like that when you're full of poop. And then the third thing that happens is that, just like your colon needs to be able to stretch to tell you that there's something in there, your bladder also needs to be able to stretch to tell you that there's something in there. And so if the intestines are in the way, so the bladder cannot actually stretch enough for the baroreceptors, those are the pressure receptors on the outside walls of your bladder, to say, oh, there's something going on in here, you're also not going to get that relay sent to your brain. The last thing that happens is that when you continually override messaging from your pelvic organs, rather than relaying to your brain, it actually just turns into a reflex arc, where you'll frequently find that they'll be completely unaware of the need to go until the instant that it's almost coming out of them, because it's gone from being volitional to being a reflex arc. So the treatment for this is medical management, consistent medical management for months. And once you have easy daily stools, I'm going to say for 90%, if there's no organic cause, right? If the child doesn't have Hirschsprung disease or something else, some other high organic complexity, 90 to 95% of the time, it's going to be far easier to get that child on the toilet. And they're going to be proud of themselves. They're going to be clear. They're going to be clean. They're going to sleep better. They're going to eat better. It just makes all the difference in the world.
So you work with continence for those under 22. What are the similarities and differences between continence challenges in that age range versus later in adulthood?
I may not be fully skilled to answer it, only because the pediatric continence and pediatric pelvic health have really been my area of expertise. I will say anyone can develop a continence issue at any point in their life. And it's really common for women, for example, after carrying children, or, pregnant individuals after carrying children, that their pelvic floor will be, and their continence will be severely impacted. And that's not only because they had all this weight, pushing down, sitting on their pelvic floor for months and months and months. And actually, what happens when you've had all of this weight on your pelvic floor and increased internal pressures, right? You've got a higher blood volume when you're pregnant, et cetera. What happens is that the musculature of your pelvic floor is going to go hypertonic, right? It's going to basically grab on and hold on because it doesn't want to fall out the bottom. And so then after you have a baby, your pelvic floor muscles, even if you haven't had a vaginal birth, your pelvic floor muscles are very used to being in that hypertonic position. And so one of the things that I do know that happens to a lot of people after they've given birth is that they develop what's called paradoxical contraction, where we actually need to relax the muscles of the pelvic floor in order to urinate or stool. But instead, they may not even realize it, but they're actually tightening the muscles of the pelvic floor. And part of the reason they might be doing that is, again, the resting tone of the pelvic floor is so much tighter, and yet it's not resilient anymore, right? It's not dynamic anymore. It doesn't have the appropriate dynamic range of motion anymore, basically. But then the other thing that happens is that when you've had all your internal organs reorganized by having a human being inside of you, obviously the other walls of the other surfaces of your abdomen, of your trunk, right? Your anterior abdomen, your back, and your diaphragm are not necessarily lined up the way that they need to be anymore, right? And in order to recruit the musculature appropriate to have a successful bowel movement, for your pelvic floor to be able to relax, you actually need to be able to recruit your anterior abdomen, and your diaphragm needs to be creating that sort of positive pressure onto your abdomen. And so all of that changes, right? If your diaphragm isn't over your pelvic floor anymore, then it's just going to get worse over time as things sort of get farther away from each other, essentially.
Well, for a pediatric specialist, you seem to have a very good handle on the postpartum and partum continence.
Well, I am also a person that carried a baby, so
lived experience,
special area of interest, right? And so mommy constipation is a very real issue. Again, it's like not my area of expertise, and because of the way that I've worked my entire career in doing anything continence and pelvic related, I've never done manual therapy. If you were to ask me any questions about biofeedback or manual therapy, I know the most vague information about it. But it's a really common issue among people in that postpartum period and beyond, that you just can't poop anymore. And a lot of these women would never recognize that they've entirely lost the urge to go. Like, that's part of the issue, is that, like I said, if you intentionally or accidentally are withholding your poop for any period of time, you do lose the urge to go. And it's a self-perpetuating cycle.
Mm-hmm.
Yeah.
So it seems like the main takeaway is that most incontinence, at least for children, is constipation related, or directly caused or perpetuated.
So yes, by a very, very large margin, the vast majority of childhood incontinence is caused by constipation. Dawn Sandal-Seedy, who is a physical therapist from Colorado, and she travels worldwide training folks on continence and rehab-based interventions for continence, sort of says the same thing that I say. Like, if I wanted to keep myself in the job, I wouldn't tell you all that they're just constipated. And her tagline is, "You're constipated until proven innocent." It's really true. When I do my intakes for the Continence Project, 9 times out of 10, the last 10 minutes of my intake is the same parent education, which is, these are the symptoms of constipation. They're not what you think they are. And you need to go to your pediatrician and you need to discuss an intervention for that constipation.
So I don't want to be, as I said at the beginning of the show, this is not meant to be prescriptive and diagnostic, but do you have red flags or general advice for parents who are concerned that, or who might be hearing this and saying, well, my child's having some challenges, maybe it's constipation, what should I do?
Yeah. Well, so the first thing I would say is, if your child is not having a full daily bowel movement, they're probably constipated. If your child is having a full daily bowel movement, they may still be constipated. And if your child is not having a full daily bowel movement and they are 4 years old or older and they are not continent yet, I will almost guarantee you that they are constipated. So aside from this question of a full daily bowel movement, you also want to be looking at what the consistency of that bowel movement is. So there's something that's widely available. We can share a link after this so folks can look at it. Something called the Bristol stool chart, which is sort of considered to be the gold standard for folks identifying what their or their child's stool looks like. And it's a 1 through 7 chart. Number 1 being sort of small, dry rabbit pellet type poop. Number 2 being a more like a sausage or a log, but it's very dry and cracked. 3 is sort of a little bit smoother. 4 is sort of that like smooth. I told you we were going to talk about poop a lot, right? That sort of smooth, tapered sausage, all the way up. And so often folks will say, there's no way my kid is constipated because there's poop coming out of him all day and it's like leaky and wet. And that's not constipation. They never stop pooping. Well, actually, that is the number 1 sign of constipation. Your child is so constipated that there is less dry poop coming around the dry poop because it is so desperate to clear all that waste out of your body. So number 1, if your child is pooping multiple times a day, if they're having very small bowel movements or very dry pellety bowel movements, I will give you a 99% level of certainty that your child is probably constipated. If your child has very, very large bowel movements, I like to say wider than 3 fingers, they are probably constipated. How do we know that? Because the shape and size of your stool can't get any bigger than the shape and size of your colon. Your colon should not be wider than 3 adult fingers, even in an adult. It should not be wider than 3 adult fingers. So if they're having these huge poops, particularly if they have huge poops and then maybe they don't poop for a couple of days or they don't have accidents for a couple of days, they're constipated, right? Because then what's happening is they're refilling the bowel after that. It's just basically, instead of being like a tube, it's become like a pocket, essentially. Also, if they have really, really thin snake-like poops, they're probably also constipated. If they're peeing super duper duper frequently, they may be constipated, right? And the bowel is basically sitting on and impinging the bladder. If they're getting UTIs, they may be constipated and they're leaking, and unfortunately they're getting bacteria. It's particularly an issue in little girls, right? They're getting these UTIs from basically E. coli getting into their vagina and into their urethra. And yeah, if your child has a really limited diet, picky diet, it's a fair sign that they may be constipated. Kids' appetites improve significantly when they are no longer constipated. And if they're not constipated, which they probably are, the fact that they have a really picky diet most likely puts them at risk for constipation as well.
Okay.
Yeah.
So do you have any advice for parents that suspect their child might be constipated after hearing this?
Yeah, right. Don't refer to me because I will just say the exact same thing to you that you just heard on this recording. That's number 1. So yes, this is what I will say. I work with a lot of pediatricians and I have really good relationships with a lot of pediatricians. And in my experience, pediatricians are very hesitant to treat constipation as aggressively as they need to because it's unpleasant. But unfortunately, what happens is that then the kids don't get better. So if you suspect that your child is constipated, the right thing to do is to go to your pediatrician, present them with the reasons that you think that your child is constipated. And it's often really helpful to take data, right? Data about how frequently your child is stooling, data about the consistency of that stool. And then the part that pediatricians tend to miss, that is, I think, an essential step in the process of treating constipation, is what's called a clean out. Or as one family referred to it recently, a blowout, which is a very, very high dose combination of laxatives that will actually make sure that all of the stool that is in the bowel comes out. And unfortunately, some of these kids, they're even ones who their pediatricians say they're not constipated, nope, everything's fine. They will, when they do these clean outs, some of the things that come out of them, they say are the consistency of old leather. It's like that hard and calcified inside of them, right? And so you need to do this full clean out, because what will often happen is pediatricians will say, oh yeah, try Miralax, try mag citrate, try like lactulose, whatever the kind of like easy does it intervention is. But remember, if you've never actually cleaned out everything that was in there, you can't be sure that you're not getting backed up again, right? And then what you have to do after that, as I mentioned earlier, is make sure you keep your child on whatever medication regimen, whatever treatment regimen you choose for ongoing management. You need to use it for an absolute bare minimum of 3 months. And this is where folks get really hung up. You have to use it for an absolute minimum of 3 months, because even in the mildest cases of chronic constipation, that is how long it's going to take for your colon to regain its tone, so that when the poop comes into you in the future, it doesn't just hang out in there, it doesn't just get caught up. And so that, again, your colon can regain the appropriate stretch so that it can send a message to your brain. I've seen miraculous things with parents who say, we've tried everything. We've tried everything. My kid's been on Miralax for years. And I say, you need to do a full clean out and then find the right Miralax dose. And it makes all the difference in the world. You need a plan for maintenance, and then you need your pediatrician to tell you, what are the signs that I need to do something more? What are the signs that I've got a problem and I need to do some intervention? Because as soon as you get off of it, as soon as you lose your maintenance, it's like you have to start all over again. And then I often say, like, if you make that appointment and you have a clean out and then you get on your dose, don't discontinue it just because your maintenance dose, just because it's because your child's stool is too watery or too loose. Work with your pediatrician to find the right dose and stay with it. And don't discontinue until you go back to your pediatrician and discuss it with them.
Well, thank you so much for coming on today. I feel like we've learned a lot and talked a lot about poop, which is important.
I know. I consider myself to be a pretty educated person when it comes to both health and wellness and my field of occupational therapy. And even I did not really understand this issue until a couple years into doing what I do now. And I don't usually consider myself to be sort of a zealot or a fringe person. And I want to just share that, like, the things that I'm sharing are not zealoty or fringy. What they are is information that is what people at the International Children's Continence Society know, what, pediatric urologists and gastroenterologists know, but it's not anything that folks are really finding out on a regular basis. And if I could spread that message, I feel like I will have done the world a huge favor.
That was occupational therapist Chayah Lichtig. I hope you enjoyed. If you like what you heard, you can always leave a 5-star review on the podcatcher of your choice. It really does help out quite a bit. You've been listening to Resilience Radio. Take care.